It's time for part 2 of the anatomy PYQs from FMGE Recall Rush. Get ready to tackle some questions and grasp the concepts with ease. Think of it as your very own mock test before the big FMGE. Do comment how many questions you get right. Without further ado, let's jump straight into the first question.
Question 1. A patient presents with a cyst on the neck anterior to the sternocleidomastoid at the junction of the upper and middle third of the muscle. This cyst is due to the persistence of which of the following embryological clefts? Here are the options. A. First cleft. B. Second cleft. C. Third cleft. D. Fourth cleft. And the correct option is B. Second cleft. Here's the explanation.
I also want to know what is happening to cleft. Where is cleft? I don't see cleft. You see, this is cleft 1, and this is cleft 2, and this is cleft 3, and this is cleft 4. So there are 4 clefts. Yes, these are clefts. Okay, fine. Lined by ectoderm. Yes, ectoderm. What is happening to clefts? That we'll find out here. So this is the next stage. Yes. What is happening now? You see, these are the inner endoderm. Yes. Pouches. Yes. What are they doing? We want to see. We also want to know what is this cleft doing, which are on the outside, lined by ectoderm. Let us find out. Understand. Pharyngeal cleft 1 will become external auditory meatus. If you say pharyngeal cleft 1 will become external auditory meatus, I think it will be lined by some surface ectoderm, because any external opening is lined by surface ectoderm. So this is pharyngeal cleft 1. What is happening to cleft number 2, 3, 4? They are gone. They are obliterated. How the cleft number 2, 3, 4 are obliterated? Because the mesoderm of the second arch will cover them. So mesoderm of second arch will cover them. Yes. You're telling mesoderm of second arch will cover the cleft number 2, 3, 4? Yes. And cleft number 2, 3, 4 will be obliterated. Yes, you see. They'll form a cervical sinus. What is sinus? Sinus means a blind sac with one opening, sinus. So cervical sinus, neck region, there is a blind sac with one opening, cervical sinus. Yes. A remnant of cleft number 2, 3, 4. Yes. Later it will become a cyst, and then the cyst will disappear. You're telling there was cleft number 2, 3, 4? Yes. And which is then covered by mesoderm of second arch, overgrowing it. Yes. And then this cleft number 2, 3, 4 will be obliterated to form a cervical sinus with one opening. Yes. And the opening will disappear to form a cyst. Yes. If the opening disappears, it will become a cyst, the cervical cyst, and then it should disappear. And what if it does not disappear? Then it is surgery problem near the angle of mandible. Branchial cyst near the angle of mandible, branchial cyst.
Question 2. Identify the histological image below. Here are the options. A. Pseudostratified columnar epithelium. B. Non-keratinized squamous epithelium. C. Stratified squamous epithelium. D. Transitional epithelium. And the correct option is D. Transitional epithelium. Here's the explanation.
Now, talking about the transitional epithelium, we have mentioned earlier that it is a stretchable epithelium, and one example we have seen was in the urinary bladder. We are taking the specimen from here and we are enlarging it further, and we'll be still magnifying it. We have to understand that the epithelium here can be having 8 to 10 cell thick appearance, but it can change into 2 to 4 cell thick appearance also. And why is that happening? Let us look at the next diagram. It is understood that if the urinary bladder was having very little urine, it is a relaxed bladder, then the lining epithelium can be 8 to 10 cell layered. But even the superficial cell will be sending cytoplasmic extension reaching the basal membrane. And since each cell is attaching to basal membrane, it does not qualify as stratified. It is called transitional epithelium. As it transitions, you see, when there is urine in the urinary bladder, it is stretched. Now the thickness of the epithelium is 3 to 4 cell. So it is undergoing transition from 3 to 4 cell into 8 to 10 cell depending upon the presence or absence of the urine. Now it can give us the wrong appearance and we can get confused it with the stratified squamous epithelium. Then how do we differentiate it from stratified squamous epithelium? See, in stratified squamous epithelium, the topmost cells are squamous cells with flat nucleus, which is not the case in transitional epithelium. The superficial cells, the topmost cells, are not flat cells with flat nucleus. nucleus. They are actually very large cells, globular cells, and there is ample amount of cytoplasm above the nucleus. We understand in squamous cells there will be very thin peripheral rim of cytoplasm. So this is not a squamous cell. And moreover, these cells, they appear like umbrella-shaped cells. Let us draw it here. As you look at these cells, they give the appearance of an umbrella, as evident here, or more evident in this diagram here. So this kind of appearance, which you find the umbrella-shaped cells, they are typically seen in the transitional epithelium, and these are, though appearing as squamous cells, but they are not, since they are globular cells, very large cells, especially seen when the urinary bladder is empty. So this is the transitional epithelium as seen in the urinary bladder. It is also present in the ureter and the proximal urethra.
Question 3. A woman presented with a sudden onset of dysphagia, dysarthria, and gait ataxia. MRI revealed an acute infarct in the right dorsolateral medulla. What is the likely diagnosis? Here are the options. A. Dejeron's anterior bulbar syndrome. B. Wallenberg syndrome. C. Babinski-Nagiot syndrome. D. Weber syndrome. And the correct option is B. Wallenberg syndrome. Here's the explanation.
Wallenberg syndrome, which is lateral medullary ischemia, clinical feature number 1, vertigo. Why vertigo? Due to injury of the lateral medullary ischemia, there is injury of the vestibular nucleus. What is the clinical feature number 2? It is ipsilateral loss of pain temperature on the face. Why in Wallenberg syndrome you have ipsilateral loss of pain temperature on the face? Because of injury to the lateral medullary ischemia and the spinal sensory nucleus of trigeminal. And what about the clinical feature number 3? That is loss of taste sensation from the same side of tongue. Why there is loss of taste sensation from the same side of tongue? Due to injury of nucleus tractus solitarius. So there is injury of nucleus tractus solitarius, and then there is some ipsilateral loss of taste sensation. Means if you put the sensation on the same side of the tongue, then there will be no loss of taste sensation. Actually, you cannot feel the taste. That is the point. Due to injury of nucleus tractus solitarius. What is the clinical feature number 4? That is here, difficulty speech swallowing. Difficulty speech swallowing. But why there is difficulty speech swallowing? Because paralysis of the palate, pharynx and larynx muscle. Why they are paralyzed? Because injury of nucleus ambiguus.
Question 4. Identify the anatomical structure marked in the given image. Here are the options. A. Abductor pollicis brevis. B. Extensor pollicis brevis. C. Abductor pollicis longus. D. Extensor pollicis longus. And the correct option is D. Extensor pollicis longus. Here's the explanation.
It is one landmark which we were talking about in the previous discussion, and is named so because in olden times the powdered tobacco was kept into this space and for the purpose of inhalation. The etymology of the anatomical snub box, how the name was derived, and it is actually bounded by 2 extensor tendons for the thumb. The short tendon extensor pollicis brevis coming from the posterior forearm is anterolateral boundary, whereas the long tendon from the posterior forearm extensor pollicis longus will be lying in the posterior-medial boundary. So bounded by the 2 extensor tendons is anatomical snub box. But then anteriorly you'll have one additional tendon. You can actually remember a mnemonic AAA. Anteriorly you have additional boundary, and that is abductor pollicis longus, again coming from posterior forearm. If you remember, this abductor pollicis longus, the long tendon, extensor pollicis brevis, the short tendon, they were passing through the first compartment of extensor retinaculum, whereas the extensor pollicis longus passes the third compartment of extensor retinaculum. That time we mentioned the anatomical snub box lies between the compartment number 1 and 3. So we'll be having a better idea in a diagram. Now what about the clinical relevance? You know, the radial artery can be palpated at the lower end of the radius. You can take the pulse of radial artery here. At the lower end of radius, then it moves into the anatomical snub box. It is a content of an artificial snub box, and you can take the pulse there as well. Against the bone scaphoid. Scaphoid bone lies at the floor of the anatomical snub box, and it has one relevance there. If there is a fracture of scaphoid, there will be tenderness in anatomical snub box. Now there are some structures which are at the roof of anatomical snub box. As we know, there is a dorsal venous arch on the dorsum of the hand, and radially, laterally, it continues as cephalic vein. The cephalic vein will be at the roof of anatomical snub box. After that, it keeps moving laterally, and then it has to drain into the axillary vein. But here, it was at the roof of anatomical snub box. There is another structure at the roof, the cutaneous branch of radial nerve. As it comes to supply the 3.5 fingers on the dorsum of the hand, it was lying at the roof of anatomical snub box. Here is the diagram which is showing us about the landmark called as the anatomical snub box. And it has two extensor tendons as its boundary, both coming from the posterior forearm region. Both are the extensors of the thumb. As we discuss, a muscle with short tendon, the extensor pollicis brevis, forming the anterolateral boundary of the anatomical snub box. And if we are talking about the long tendon, it is the extensor pollicis longus, coming from the posterior forearm and forming the posterior medial boundary of the anatomical snub box.
Question 5. Which of the following arteries is palpated in the image shown below? Here are the options. A. Anterior tibial artery. B. Posterior tibial artery. C. Dorsalis pedis artery. D. Popliteal artery. And the correct option is B. Posterior tibial artery. Here's the explanation.
There is a posterior tibial artery which is bringing the blood from the heart towards the periphery. And sandwiching this posterior tibial artery, you'll find there are two veins sandwiching the artery having the same name, posterior tibial veins, which we can show here. And they are known as venae comitentes. This term, venae comitentes, is a general term which is applied not only for posterior tibial veins, but any other veins like fibular vein or anterior tibial veins, because they are all running in a pair, sandwiching the corresponding artery having the same name. So what is the purpose of having two veins instead of one, and why are they sandwiching the artery? See, the veins are coming from periphery towards the center, so they'll be carrying cold blood from the periphery towards the center. They need to gain some heat, and they gain that heat from the artery, because the artery is coming from the heart towards the periphery, will have warm blood. So heat exchange can occur between artery and veins. That is one property of venae comitentes. Number 2, these veins, they are running against the gravity towards the heart, and veins, they do not have pulsations like artery. Now the artery which is having pulsations can be utilized by the veins. Since this structure shown here is all covered by the dysphagia, it is a tight compartment, and the pulsation of the artery can be transmitted towards the veins, and those pulsations will help these veins to continuously keep pushing the venous blood towards the heart. So that is another advantage of this arrangement of venae comitentes.
Question 6. The fallopian tube is lined by. Here are the options. A. Simple columnar epithelium. B. Pseudostratified ciliated columnar epithelium. C. Ciliated columnar epithelium. D. Cuboidal epithelium with microvilli. And the correct option is C. Ciliated columnar epithelium. Here's the explanation.
We are going to focus upon the type of questions which they are asking and go through the details accordingly. For example, regarding the mammary gland, we have to understand it is a modified sweat gland and belongs to apocrine variety. So modified apocrine sweat gland. Then we have to discuss the epithelial lining. For example, the ovary. Ovary is lined by the simple cuboidal epithelium. And what about the uterine tube? As we talk about the uterine tube, we will find that it is having simple columnar epithelium. We'll be drawing a diagram ourselves to discuss the details, but some of the cells in this simple columnar epithelium will be having cilia also. So you can remember the uterine tube is lined by ciliated columnar epithelium.
Question 9. What is the type of collagen seen in cartilage? Here are the options. A. Type 1 collagen. B. Type 2 collagen. C. Type 10 collagen. D. Type 7 collagen. And the correct option is B. Type 2 collagen. Here's the explanation.
Elastic cartilage is having elastic fibers and that is why it is deformable. But as you leave it, it will come back to its original shape like the pinna. And you know how to identify the elastic fibers? You have to do special stains for elastic fibers and they have typical features as we have learned. SSSB. What is the full form of SSSB? The elastic fibers are short length compared with the collagen fibers and they are straight, not wavy as collagen fibers. And then they are running single, not in bundles, but they do have branching. Now understand, in the elastic cartilage along with the elastic fibers, you'll have the collagen fibers also. As you know, made with a hyaline cartilage or elastic cartilage, they will have type 2 collagen fibers. So they are present in the elastic cartilage along with the elastic fibers.
Question 10. A man was brought to the emergency department after he fell into a manhole and injured his perineum. He was unable to pass urine and blood was seen at the tip of the urethra. A diagnosis of bulbar urethral injury was made. Where do you least expect the urine to get collected in this case? Here are the options. A. Perineum. B. Anterior abdominal wall. C. Medial portion of the thigh. D. Root of the scrotum. And the correct option is C. Medial portion of the thigh. Here's the explanation.
Straddle injury and rupture of bulbous urethra. So straddle injury, what is straddle injury? We'll see that. But straddle injury, the urine can be at 4 places. Now, this is a rupture of the urethra below perineal membrane and urine at 4 places. What 4 places? So, you have to understand that there is a Scarpa's fascia on the anterior abdominal wall and the Scarpa's fascia is continuous with the penile fascia and it is continuous with the scrotal fascia and the scrotal fascia is continuous with the Colles fascia and Colles fascia is continuous with the perineal membrane. So there is a closed space and urine at 4 places if the rupture was below perineal membrane, bulbous sponge urethra rupture. So which 4 places you have urine? In the superficial perineal pouch below the perineal membrane and also going into the scrotum penis and also going anterior abdominal wall. Anterior abdominal wall under the Scarpa's fascia, and in front of the pubis bone, in front of this pubis bone, it is going.
Question 11. What type of joint is seen in the labeled structure? Here are the options. A. Syndesmosis. B. Primary cartilaginous joints. C. Fibrous joint. D. Secondary cartilaginous joint. And the correct option is D. Secondary cartilaginous joint. Here's the explanation.
Let us focus upon secondary cartilaginous joint. The midline intervertebral joint or pubis symphysis. This is example of symphysis. And what you notice is under symphysis, there are some examples like midline intervertebral joint. As you can see, shown here between the upper and lower vertebra, plus one example, the pubis symphysis. Now, both of these joints are secondary cartilaginous joint or symphysis. What is the structure type and what about the mobility? When you talk about the structure, you will find vertebral bones are developing in hyaline cartilage by endochondral ossification. So they are having some hyaline cartilage lining. You can show here vertebra having some hyaline cartilage lining. And this hyaline cartilage lining the each vertebra is sandwiched by intervertebral disc, the shock absorber. You know it is made up of fibrocartilage. So the structure type you can understand. There is one vertebra articulating with other vertebra. Between the 2 bones you have hyaline cartilage on either end and sandwiching them is the fibrocartilage intervertebral disc. So when 2 bones are united by hyaline cartilage plus the fibrocartilage, this type of a joint, which is usually in the midline, is called as symphysis or secondary cartilaginous joint.
Question 12. A 34-year-old male patient presents to the OPD with complaints of pain in the medial part of the elbow for the past 4 to 6 weeks. He gives a history that the pain worsens while lifting weights in the gym. On examination, there is tenderness over the medial epicondyal, and reverse Cousins test is positive. Which of the following nerve is most likely to be injured in this patient? Here are the options. A. Median nerve. B. Ulnar nerve. C. Radial nerve. D. Axillary nerve. And the correct option is B. Ulnar nerve. Here's the explanation.
let us compare this with the injury at a higher level, which is, say, for example, behind the medial epicondyle. So, ulnar nerve lesion behind the medial epicondyle. Again, it will be leading to paralysis of the lumbricals and interossei and ulnar claw hand, but there is less of clawing. And why there is less of clawing? Because if the nerve lesion is at this level, the flexor digitorum profundus is also getting involved. And this was the muscle which was actually bringing the clawing, the flexion of the fingers. If it is paralyzed itself, then it cannot fold the fingers. Hence, the fingers are in less of folding or less of clawing. So, a nerve lesion at a higher level, there is less of clawing, since the muscle which was causing IP flexion itself is not working, as compared with the lesion at a lower level when there was more of clawing, because that clawing or interphalangeal flexion was happening due to the unopposed flexor digitorum profundus.
Question 13. A drowsy man was brought to the casualty with minimal response. He had a progressive history of weakness in his body for 2 days. A CT scan was taken, which is shown below. Which vessel is likely to be thrombosed? Here are the options. A. Posterior cerebral artery. B. Anterior cerebral artery. C. Middle cerebral artery. D. Posterior inferior cerebellar artery. And the correct option is C. Middle cerebral artery. Here's the explanation.
Middle cerebral, let us see, middle cerebral. Middle cerebral artery is the major artery on the lateral cerebrum, supplying the Wernicke's area and the Broca's area, etc., etc. And it is running in the lateral sulcus. Where? In the lateral sulcus. You mean to say internal carotid artery gave you middle cerebral artery? Yes. And this internal carotid artery when gave you middle cerebral artery run in the lateral sulcus. Yes, it is supplying lateral cerebrum. And then this is the diagram we are following. So let us follow the diagram. What is it about? See, this is the middle cerebral artery. Where? In the lateral sulcus of brain. What is it doing? It is giving some branch to the occipital visual cortex. Which area? That is called macular area. So you are telling that macular area on the brain is supplied by some branch of middle cerebral artery. That is why there is macular sparing in occipital cortical blindness. Yes, that's why. And this middle cerebral artery is also supplying Broca's area. If it is compromised, there will be hesitant patient to speak. Fluency is gone. Motor aphasia. And what if the branch 2 Wernicke's area involved? Then patient is very talkative and talking nonsense because comprehension of language is gone. It is sensory aphasia. And what if the branch of middle cerebral artery compromise here? Branch of the middle cerebral artery compromise here, then there will be upper body homunculus compromise. Sensory motor loss in the head and upper limb. Sensory motor loss in the head and upper limb. What about the pelvis perineum? No, not pelvis perineum. Why not pelvis perineum? Because that is where you have this artery. Who is that? Anterior cerebral artery, branch of internal carotid artery. So, internal carotid artery gave you anterior cerebral artery supplying this area. Pelvis perineum? Yes. Pelvis perineum area is under anterior cerebral artery, not the middle cerebral artery.
Question 14. Which of the following develops from the dorsal mesogastrium? Here are the options. A. Falciform ligament. B. Spleen. C. Lesser omentum. D. Liver. And the correct option is B. Spleen. Here's the explanation.
You remember we were talking about the liver developing in ventral mesentery and having one lesser omentum attaching to lesser curvature of stomach, and the stomach itself is having lesser curvature anterior, greater curvature posterior, and the spleen is developing behind the stomach in the dorsal mesentery. So, this is the stomach having lesser curvature anterior and having lesser omentum attaching to liver anterior, developing in ventral mesentery. And this is spleen developing dorsal mesentery, having a ligament with the greater curvature. Can you tell me the name? Splenogastric ligament attaching to greater curvature of the stomach. This is in the beginning.
Question 15. The X-ray showed an antero-posterior view of a normal elbow. What is the structure marked in the image called? Here are the options. A. Capitulum. B. Trochlea. C. Olecranon. D. Head of radius. And the correct option is A. Capitulum. Here's the explanation.
There we are going to have the two condyles and epicondyles at the lower end of the humerus. There is a lateral condyle and medial condyle. The lateral condyle is called as the capitulum and it is working like a cap on the lateral bone. That is the radius bone in the articulation. So this is the capitulum, like a cap on the head of the radius bone, and it is actually the lateral condyle of the bone humerus. On the medial side there is a pulley-shaped structure, hence called as the trochlea. So trochlea is the medial condyle at the lower end of the bone humerus and is going to articulate with the trochlear notch of the ulnar bone hair, contributing to the elbow joint, which is basically humero-ulnar joint. Now, may it be the trochlea or the capitulum, both of them are pressure epiphyses and they are involved in weight transmission. So pressure epiphyses are intracapsular within the capsule of the joint. Here you can notice the attachment of the capsule of the elbow joint, and it is evident that both the condyles are intracapsular. This is in contrast to the traction epiphyses, which are always extracapsular. So where do we see the traction epiphyses here? It is the lateral epicondyle and the medial epicondyle.
Question 16. Celiac vessel is seen at which vertebral level? Here are the options. A. T9, B. T10, C. T12, D. L2. And the correct option is C. T12. Here's the explanation.
First of all, you should know at the T12 level, there is an opening in the diaphragm for the passage of aorta through the aortic hiatus. That is the beginning of abdominal aorta. Terminal point is L4. At L4, vertebra it will bifurcate into two branches. So, extent of abdominal aorta, it is from T12 to L4 vertebra. And after that, what it is doing? It is bifurcating into two branches called common iliac artery. And common iliac artery further will bifurcate into two branches called internal, external iliac artery. So, you are telling that L4 vertebra, there is the bifurcation of abdominal aorta into two branches called common iliac, which will further divide into internal, external iliac artery. Yes, that is what we have to discuss. Okay, if you say so. Where is the celiac artery given, the artery to foregut? If you say celiac artery to foregut, it is between T12 and L1. T12 and L1. So, between T12 and L1 is the celiac artery given, which is for the foregut. Where is the superior mesenteric artery given? Superior mesenteric artery and renal artery are given almost at the same level. But superior mesenteric artery is superior to renal artery.
Question 17. Which single muscle is involved in the actions of the arm's flexion, adduction and medial rotation? Here are the options. A. Serratus anterior. B. Pectoralis major. C. Pectoralis minor. D. Subclavius. And the correct option is B. Pectoralis major. Here's the explanation.
We are specifically focusing upon the pectoralis major and the serratus anterior, though the pectoralis minor and subclavius may also sometime come in the questions, but our focus should remain upon these two major muscles. The pectoralis minor is a small muscle under pectoralis major, and when it comes to subclavius, it is a muscle under the bone clavicle. Presently, let us move on to this large muscle in the pectoral region, the pectoral major. It is a large muscle on the anterior thoracic wall and is a convergent muscle. Means its origin is quite extensive, but the insertion is where the fibers are converging. So big origin and smaller insertion. The fibers are converging, convergent fibers. And along with the fibers being convergent, it is also having spiral fibers. Now, what do we understand by the term spiral? Let us look at that aspect as well by first looking at the origin of the muscle. It originates from the anterior aspect of the clavicle bone, sternum bone, and the costal cartilages attaching there of the upper ribs, and a lower origin from external oblique aponeurosis. There is a muscle in the anterior abdominal wall external oblique muscle. Its aponeurosis gives the lower fibers of pectoralis major muscle origin. The same you can depict here as well. It has a clavicular origin and a sternal origin from the anterior surface of the sternum along with the costal cartilages of the upper ribs giving some fibers, and then we have got external oblique aponeurosis as the origin. And after taking such an extensive origin, the fibers are now converging into a narrow area. That will be the insertion, which is lateral lip of the bicipital groove. If you remember, we have discussed lady between two majors, and this is the lateral major, pectoralis major. Now, there is one more description. When the fibers are inserting on the lateral lip of bicipital groove, the upper fibers are inserting at a lower level, whereas the lower fibers are inserting at the upper level. You can see that here, the muscle is having spiral fibers. It is twisted by 180 degree at the insertion. That means the upper fibers of the muscle, as you follow them, they are going to be inserted at a lower level. And if we are talking about the lower fibers, then you will see they are going to be inserted on the upper aspect here. So there is basically spiraling of the fiber by total of 180 degree. And that is why it is known as a spiral muscle. It will become more evident when you look at a magnified diagram. See the upper or the clavicular fibers. As they are coming, they are going to be inserted at a lower level. And if you're comparing them with the lower fibers, you notice that they are spiraling now to be inserted at the upper aspect of the insertion level. So what it means is there is a total of 180 degree spiraling of the fibers while they are inserting. It becomes more evident when you look at this diagram. This is the clavicular origin, the upper fibers, which are now coming to insert at a lower level. And if we are talking about the lower fibers which come from the external oblique aponeurosis, lower costal cartilage or lower sternum, you can see them. These fibers are converging onto upper level, and that is what we are telling. It is 180 degree spiraling of the fibers. What about the middle fibers? As you see, the middle fibers are staying in the middle as evident here, which you can show even here. The middle fibers taking origin from sternum are staying in the middle region. So these are converging fibers and they are also spiral fibers. Now we want to talk about its nerve supply and action as well. And we notice that this muscle is being supplied by lateral and medial pectoral nerves. As we understand that in the axilla we have brachial plexus, there are three cords of brachial plexus. The lateral cord will give lateral pectoral nerve and the medial cord of brachial plexus gives medial pectoral nerve. And since this muscle is a large muscle supplied by two motor nerves, it qualifies being called as hybrid muscle with more than one motor supply. Now, what about its action? Remember a simple rule. Any muscle which will cross the shoulder joint anteriorly and inserts on the humerus bone, it will pull the humerus towards the midline, or what you call as ADD, adduction. Plus, as it is pulling the humerus inside, it is also doing medial rotation, as is mentioned here, adduction and medial rotation. Plus, you have to understand pectoral major, especially the clavicular fibers. They continue pulling the humerus towards the midline, and this is what we call as flexion at the shoulder joint. So as you're folding the humerus, it is flexion, and if you take it back, it is extension. So which muscles will be doing extension? The muscles which are on the posterior aspect, they'll pull the humerus posterior, causing extension. One more thing, as we mentioned, if the fibers are crossing the shoulder joint anteriorly, they were medial rotator. But if the fibers are crossing shoulder joint posteriorly, they'll rotate the humerus posteriorly. That means lateral rotators. So posterior fibers are going to be lateral rotators and also extensors, which we'll discuss in some of the muscles which belong to posterior axio-appendicular skeleton. See here, pectoral major is anterior. Axio-appendicular will have some muscles which are posterior and will be antagonizing the action of pectoral major then.
Question 18. One of the nerves supplying the upper limb, the upper lateral cutaneous nerve of the arm, supplying the skin overlying the posterior border of the deltoid muscle as well as covering the long head of the triceps, is a branch of. Here are the options. A. Musculocutaneous nerve. B. Radial nerve. C. Ulnar nerve. D. Axillary nerve. And the correct option is D. axillary nerve. Here's the explanation.
As we have seen, the posterior quadribrachial plexus giving upper S, lower S, and the T here. What about the A, the axillary nerve? And as you notice, the axillary nerve coming from the posterior quadribrachial plexus is followed by one artery, the artery which is going posterior to the humerus and around the humerus. That's why the name is posterior circumflex humeral artery. It is a branch of the axillary artery which is also in the axilla. And together with the axillary nerve, it is lying in the quadrangular space, as you notice here. So in the quadrangular space, you have got posterior circumflex humeral artery along with the axillary nerve. And both of them, after passing the quadrangular space, go posterior to the humerus, wind around the surgical neck of the humerus, and that is where they are prone to injury if there is a fracture at the surgical neck of the humerus. And deltoid muscle, teres minor, will get compromised.
Question 19. Which muscle originates from the medial epicondyle of the humerus? Here are the options. A. Supinator. B. Pronator quadratus. C. Pronator teres. D. Brachioradialis. And the correct option is C. Pronator teres. Here's the explanation.
Cubital fossa is a triangular space in front of the elbow joint, and since it is a triangle, it will have three sides. The base is formed by joining an imaginary line connecting the two epicondyles, the lateral epicondyle and the medial epicondyle. Medially, we have got one muscle, that is the pronator teres, and laterally we have brachioradialis muscle.
Question 20. Testicular artery is a branch of. Here are the options. A. Abdominal aorta. B. Common iliac artery. C. External iliac artery. D. Internal iliac artery. And the correct option is A. Abdominal aorta. Here's the explanation.
Now, if you say internal iliac artery is supplying the pelvic viscera, why is it not supplying the ovaries? Ovaries are also pelvic viscera. Yeah, maybe ovaries are pelvic viscera, but they are not supplied by iliac artery. Why? Because the gonads develop in the abdomen. So gonadal arteries are branches of abdominal aorta. You are telling that gonads develop in the abdomen, so gonadal arteries are branches of abdominal aorta. Yes, testicular artery, ovarian artery are branches of the abdominal aorta because gonads develop in the abdomen. Later they descend down to pelvis.
Question 21. Mammillary body is a structure on the endosurface of the brain, developing from the diencephalon that forms a part of the limbic system. They receive afferent fibers via the. Here are the options. A. Corpus callosum. B. Thalamus. C. Pituitary gland. D. Fornix. And the correct option is D. Fornix. Here's the explanation.
Now, where is the fornix, the collection of axons, carrying information from the hippocampus towards? It is towards the hypothalamus. In the hypothalamus, there are mammillary bodies, and this information is reaching the mammillary bodies. And from the mammillary body, where the information will be going towards, it is moving towards the thalamus. And which nucleus of thalamus? It is the anterior nucleus of thalamus.
Question 22. A 6-month-old infant presents to the emergency department with bilious emesis. On further investigation, it is found that the scum remains fixed in the right upper quadrant due to peritoneal bands. The infant is diagnosed with intestinal malrotation. Which of the following is the correct statement regarding the midgut rotation during embryological development? Here are the options. A. 270 degree clockwise. B. 270 degree anti-clockwise. C. 360 degree clockwise. D. 360 degree anti-clockwise. And the correct option is B. 270 degree anti-clockwise. Here's the explanation.
And when they move out, this is the DJ moving out, yes, and that is the IC moving out, yes. Now DJ and IC, because both of them belong to midgut, they have moved out the anterior abdominal wall through the umbilicus. Inside the umbilical cord, they start rotating anti-clockwise. If you are telling that they start rotating anti-clockwise. Then how much rotation they are doing? 90-degree anti-clockwise when they are inside the umbilical cord. And who is the axis of rotation? That is the superior mesenteric artery. So superior mesenteric artery, the artery of the midgut, become the axis of rotation on which the DJ and IC are rotating 90-degree anti-clockwise when they are inside the umbilical cord. Now, there is another 180-degree of rotation anti-clockwise only when the DJIC are coming back, regressing back. You mean to say there is a high point DJ, yes, and low point IC, yes. They're going outside the umbilicus to enter umbilical cord now, yes, and then they start rotating anti-clockwise 90-degree, yes, when they are inside the umbilical cord, and now they are coming back, yes. When they're coming back into the abdominal cavity, what are they doing? They rotate again 90-degree plus another 90-degree, and they are inside. Understand? DJ is a high point, IC is a low point, and they go outside to enter the umbilical cord, and the first 90-degree rotation anti-clockwise is within the umbilical cord, and remaining 90-degree plus 90-degree while coming back into the abdominal cavity. So finally, what is the situation? Finally, let us see what is the situation, but total it is 270-degree rotation anti-clockwise. So total it is 270-degree anti-clockwise. Yeah.
Question 23. Bleeding vessels in hemorrhoids is? Here are the options. A. Superior rectal artery. B. Superior rectal vein. C. Middle rectal artery. D. Inferior rectal artery. And the correct option is B. Superior rectal vein. Here's the explanation.
There can be Budd-Chiari syndrome, hepatic vein thrombosis, portal hypertension, reversal of blood flow into portal vein, into the splenic vein, into the inferior mesenteric vein, into the superior rectal vein, jumping into the middle inferior rectal vein. So you're telling that portal vein is sending blood back into the splenic vein, into the inferior mesenteric vein, into the superior rectal vein, into the lower portion, which is middle inferior rectal vein, yeah. And there is some rectal varices which are bleeding, yeah. Rectal varices can bleed fresh blood per rectum. They are also producing hemorrhoids. What is hemorrhoids? Hemorrhoids are dilated, elongated, tortuous veins, you know.
Question 24. Brunner's gland is a histological finding of which structure in the gastro-intestinal tract? Here are the options. A. Esophagus. B. Stomach. C. Duodenum. D. Liver. And the correct option is C. Duodenum. Here's the explanation.
If you remember, we have discussed proximal part of duodenum will have submucosal glands. Glands in the submucosa is a rare finding, can be seen in the esophagus and in the proximal duodenum. They are having a name also, we call them as the Brunner's gland. And what is the secretion? Brunner's gland, they give us hormone like the urogastron. We will discuss more about that, but if you find the Brunner's gland, then it is the duodenum, proximal duodenum.
Question 25. A 44-year-old male came into your clinic post-hernia repair and wants you to evaluate his condition. While eliciting the cremasteric reflex, you noticed that the scrotum did not ascend on the side of the surgery, suggesting an iatrogenic injury to the. Here are the options. A. Sacral plexus. B. Femoral branch of genitofemoral nerve. C. Genital branch of genitofemoral nerve. D. Femoral nerve. And the correct option is C. Genital branch of genitofemoral nerve. Here's the explanation.
And then there'll be some nerves. Actually, one question comes, which nerve is inside the spermatic cord? And you say it is genital branch of genitofemoral nerve. What is it for? It is to control cremaster muscle, for cremaster reflex. So genital branch of the genitofemoral nerve is for the cremaster reflex to control cremaster muscle, for testicular elevation in the scrotum. Yeah, testicular elevation in the scrotum.
Stay tuned for tomorrow's biochemistry continuation in FMGE Recall Rush. Like the video if you learned something new. Subscribe to join an active medical community. See you soon.